Good evening, everyone. It's my pleasure tonight to moderate the masterclass of migraine that is organized by the IVPN NeuroPsychiatry in collaboration with Association of Migraine Disorder and sponsored by Pfizer. Our topic for tonight is very interesting. It's titled Modern Therapies for Migraine and What Are the Challenges? And it's my pleasure tonight to introduce our two speakers, Professor Masoud Ashina and Dr. Riza Ravitz. Our first speaker, Dr. Riza Ravitz, has a private practice based in New York City. She treats patients with a wide scope of neurologic disease, but the focus of her practice is in headache medicine. She also sees patients via telemedicine across the country and internationally. She has a very busy clinic, and in her spare time, Dr. Ravitz enjoys running, surfing, and yoga. Dr. Ravitz, the floor is yours.
Thank you. Thank you for that very nice introduction. And it's very nice to see everyone remotely. It's early in New York, and I know it's later there. So thank you everyone for joining. We can start sharing the slides. So if anyone has any questions, you can write it in the chat. And I think at the end, we're going to have a question and answer session as well. Yeah, so I appreciate the introduction. And it is true, I do see a lot of patients specifically for migraine, and it's been an exciting time with new medications, an exciting time in diagnosis. So let's jump right in. So this talk is titled Patient and Clinician Perspectives and the Use of Modern Therapies for Migraine. You can advance, thank you. Okay, so I think one of the first questions, and always an important question, is to treat or not to treat. We see these patients in various settings, and it's always, that is the question, do we treat or do we not treat? So I wanted to present one or two fictional patients and go over an overview of the medicines, the medications, and the modalities that are available to treat migraine. And it's a very broad topic. It's what I do every day, but just wanted to show you how I go through my thinking about how to treat patients. So let's start with the first fictional patient. So S is a 35-year-old female. She's been suffering from migraine with aura. She works as a software engineer and gets headaches 1 to 2 times a month. She has been using triptans and NSAIDs intermittently with good relief, but she sometimes doesn't treat the headache and likes to wait it out. So the question always is, first of all, does the patient need treatment? Will she use the treatment? Because as you all know in practice, that's a challenge as well. And if she's going to, which treatment is appropriate? So please advance. Okay, so here's a quick summary, and it's not a completely exhaustive list, but a pretty good list of the modern therapies that we have around the world, and sort of the most common therapies that we use in the US here. So they're separated into 2 different categories, the abortive medications and the preventative medications. And the abortive therapies include the nonsteroidal anti-inflammatories, the triptans, the gepants, ergotamine, vitalbutal, and acetaminophen. Forgot to add aspirin on here. That's also on this list. And then tramadol and opiates, and some of the anti-nausea medicines. And the common preventative therapies that we tend to use are beta blockers, calcium channel blockers, anticonvulsants, including valproate, topiramate, carbamazepine, zonisamide, lamotrigine, and gabapentin. We use the tricyclic antidepressants and other antidepressants, including SSRIs and SNRIs. We have the CGRPs and the MABs now. We used NMDA receptor antagonists, and we use botulinum toxin therapy. You can advance. Can we advance? I'm sorry, Hussein, can you advance the slides? Dr. Rodi, is Dr. Hussan on there? I'm sorry.
can you please forward for the next slide, please?
Did he fall off the recording, maybe?
It's possible. I'm gonna. Hossein, please, can you try to go for the next slide, please?
Sorry about the delay, everyone. And I see the questions coming up in the chat. We're going to talk about a lot of these medicines.
Dr. Riza, I'm gonna take like a few seconds till Dr. Hossein will solve the problem of slides. One of our audience is asking, what's the difference between episodic and chronic migraine? How
Sure.
to differentiate
Okay,
them?
so we can answer these questions while we're waiting. So the difference between episodic and chronic migraine is basically the number of times that it occurs, typically in a month is how we measure it. So episodic migraine is typically defined as, they change it a little bit, but up to 4 to 8 headaches a month. And now chronic migraine is starting at 6 to 8 headaches a month. And those are headache days. So actual days that the patient is experiencing headache. And the way that I'll just talk a little off the cuff here, but the way that we look at it is that we want to treat patients with episodic migraine with the Board of Medicines. We want them to be able to take the medicine and then get rid of the headache. And we start to think about preventative medications when patients have more than 4 headaches a month typically, but if they have 2 headaches a month that are super debilitating, where they have nausea and vomiting, and looks like we have our screen back, when they have nausea and vomiting, or they miss work 3 days a month, we start to think about that as a more debilitating condition. Okay, so let's see here. Can you advance one slide, Hussein? Dr. Sum? Okay, back one, I'm sorry. Okay, so this is, yeah, so next slide, Husam, and we're good, thank you. Okay, so back to the patient. So again, a 35-year-old female suffering from migraine with aura. She gets 1 to 2 headaches a month. I would classify her as a patient that has episodic migraine. She's using triptans and NSAIDs intermittently with good relief, but she doesn't like to treat. So she does need treatment. And I think it's really important for us to understand why she needs treatment and also to educate the patient about why she needs treatment. Next slide, please. So this is something I see all the time in my practice, and I find it very interesting because it's very relevant to how patients decide how they want to take medicine, and it's very relevant to how we communicate with patients. So this is how a lot of times the thinking plays out. So the patient often likes to say, I don't like to put any medicine in my body. I try to wait it out. Sometimes I can just power through the symptoms, and I'm often afraid of the side effects. So as a healthcare professional, medication is a major tool that I have to offer for treatment. And what patients don't understand, especially in migraine, is when you wait to treat the symptoms, they often get a lot worse. So there is a big cascade of events that happens chemically, electrically, and there's a lot of inflammation that's created. And as that happens, it gets harder to treat the headache later on in the course of when it happens. And patients don't understand that. So for many other things, they really try to wait it out. But for migraine, it's really important that patients understand that they should take it. They shouldn't wait. They should be very aggressive, and they should take it. And, you know, as far as the side effect question, most medications do have side effects, unfortunately. But I always remind patients that, is it worse to have side effects, or is it worse to have a terrible debilitating headache with downstream effects like nausea, vomiting, fogginess, and dizziness? And that often gets people a little bit more willing to try medication. Next slide, please. So again, I cannot understate how important it is that we educate patients and tell them that these headaches need to be treated. So they need to hear this often more than once. Often it's not until the second or third visit that I actually convince a patient to take a medicine. I do tell them that migraine, I try to explain to them that migraine is a genetic neurovascular disease and our understanding of it has evolved. I do try to explain central sensitization. It plays a very big role in migraine pathogenesis. And basically, if you want to dumb it down for patients, migraine can potentially make migraine worse. It can make them more severe and more frequent. So an untreated migraine lasts longer, and frequent migraines are believed to cause more frequent headaches. So the sooner the migraine is treated, the better the outcome typically. So again, I remind the patients, are the side effects worse than the migraine? Next slide, please. Next slide. I think it repeated. Yeah. Okay. So this patient for sure qualifies, in my opinion, for abortive therapy. Again, she sometimes treats the headache, and it sounds like sometimes they're maybe undertreated. So for me, what I would do is I would offer this patient NSAIDs, triptans, Gepants, and Benadryl as tolerated. So what also happens, and this is a longer story, but sometimes when patients are taking triptans, the same one for many years at a time, and likely this patient has been taking it for many years, or even a triptan, they start to build a tolerance to it. So for example, the sumatriptan 50 milligrams that they used to take may not work as well as it used to. Or the one over-the-counter Motrin 200 milligram they were taking doesn't work as well as it used to. So I would optimize that, and I would rotate if necessary. There's 7 or 8 triptans. There's 7 triptans available, at least in the US. So I would rotate it to a different one, just trick the brain a little bit so it's not used to it and it actually will respond. And I often will change the anti-inflammatories as well. And I also offer the new Gepants. So it's a different mechanism of action. We're going to talk about that as well, but that includes Rimidipine and Ubrogepant. I do use diphenhydramine as needed, sometimes a short course. The antihistamine component of this helps with migraine, actually. So I don't use it for sleep. I actually use it for the migraine at night. Again, I'm reiterating to treat early and aggressively. I'm asking again if the side effects are worse than the headache. I reiterate the cascade of chemical and electrical events that occur when untreated. And I want these patients to have a loose headache diary, just so they're more aware themselves of how often they're getting headaches. Next slide, please. Okay, so let's go through the different abortive therapies briefly. Again, not an exhaustive list of everything about them, but just things that I noticed that are very helpful in practice. So anti-inflammatories and aspirin, the considerations and side effects. The exact mechanism of action is not completely understood. It inhibits cyclooxygenase and reduces prostaglandin and thromboxane synthesis. This is an inflammatory pathway. There is a lot of inflammation that's created in migraine, a lot of inflammation around patients that have migraine in their menses, and this is a very helpful medicine for migraine. I often choose the NSAID based on the half-life of how it works. For example, the Motrin and diclofenac tend to be a little shorter acting, and I use some of the longer acting ones to rotate patients so they get longer relief depending on how long their headaches last. So an effective dose is also very important. These patients often need anti-inflammatory dosing, especially if they've been taking this for many years. Again, many patients start with like 1 or 2 Advil that they've been taking, and that just simply doesn't work anymore. Relative contraindications, concurrent peptic ulcer disease. A lot of people don't tolerate this anymore. And there is a very strong possibility for medication overuse headache. I'm not going to get into detail about this, but medication overuse headache is defined as taking medication more than 3 times a week for over 90 days. And what ends up happening is the patient creates a true tolerance to the medicine. So the body has receptors, the receptors get filled by the NSAID, there's upregulation of the receptors, there's more anti-receptors, and this is true physical tolerance. There is a belief and theory that this actually creates more headaches. So you get withdrawal and you actually get more headaches. So I do not want my patients using this a lot. I do not want them using it more than once a week. Even that is a little bit much, but it's something to really think about. And you will see patients that, come in and they're going through a bottle of Advil every month or every 2 weeks. And again, I try to rotate medicines to trick the brain so they don't get as tolerant as they could. Next slide, please. So triptan's consideration and side effects, it works by activating vascular serotonin 5-HT1 receptors. It's a selective serotonin agonist. The dosing is important for this as well. Many doctors are afraid to start the full dosing on this, and I think using the higher dose to knock the headache out is actually more effective than starting the low dose. There are known vasoconstrictive tendencies, and this medicine is contraindicated in patients with ischemic heart disease, cardiovascular disease, uncontrolled hypertension, and pregnancy. So over the age of 60, it's reasonable, and this is how I practice. I try to get cardiology clearance. I do not use these medicines in the strict contraindicated criteria, though. Side effects for triptans: nausea, pain in chin or chest, fogginess. Those are the most common ones that I see. Next slide, please. So ergotamine, side effects and consideration. This is an older medicine, but I know it's available more widely around the world than in the US. We don't use this as much. It activates vascular serotonin 5-HT1D receptors and constricts peripheral blood vessels. It's an older medicine. It's less well tolerated. The peripheral vasoconstriction is a problem, and it's definitely contraindicated in patients with CAD, cerebral vascular disease, uncontrolled hypertension in pregnancy, and peripheral vascular disease as well. Side effects are nausea and vomiting. There's a new delivery system in the US called Trudhesa. I am using it a little bit. It's often better for younger patients who failed other treatment. They tend to be the patients that can tolerate this, and it's okay to use. Next slide, please. So the GPANs, these are the new medications. The mechanism of action is by blocking calcitonin gene-related peptide, includes rimegepant, ubrogepant, atogepant, and zavegepant. The nice thing about these medicines is that there's no real comorbid medical contraindications. It has shown in studies to not have any, which is very, very helpful. Side effects overall have been nausea, somnolence, constipation, and fatigue. You cannot use this in pregnancy. The availability of the drug around the world is variable. And the other thing that's nice about this class of medications is that no medication overuse potential has been appreciated. Next slide, please. So barbiturates, tramadol, and opiates. So I know there was a question about this in the chat, and I hope I answer your question. The mechanism of action targets opiate and caffeine receptors. There are other mechanisms of actions that are not as well understood. This is the last choice in my practice. So to answer the question in the chat as well, I do not routinely prescribe this in my practice. Interestingly, these medicines weren't even shown to be that helpful in actually stopping the migraine. A lot of people just end up falling asleep, and then the headache naturally goes away. So it's not really a treatment, but it's a treatment that's often given in the ER or by physicians that are not aware of the other treatments that we use for migraine. So I do try to avoid this. These medicines are highly addictive. They definitely contribute to medication overuse headache. So the barbiturates and the Fioricets it's an old medicine that people use a lot of, and very, very addictive and hard to wean. And those headaches are not going to get better until the patients are off of the medicine. So I really don't use this very much in my practice. Next slide, please. So the nausea medicines, these are just a few that are commonly used. Metoclopramide is most commonly used. The mechanism of action is not exactly understood, but it does stimulate upper GI tract motility, which is impaired in migraine. So the motility goes down when there's a migraine, whatever's in the stomach, the patient throws up. This helps with restoring that downstream side effect, and it also helps with absorption of the other medicines. So it's very helpful. We use ondansetron a fair bit. This acts centrally in the brain, antagonizing serotonin 5-HT3 receptors. It's strong and effective. We use chlorpromazine a little bit, selectively antagonizes D2 receptors, but has some potential anticholinergic effects. So I don't use it as much, but it is a good medicine. So I'm always considering the delivery and aid to the absorption of the abortives. The ondansetron comes in a melt. So for some patients, that's better because they're vomiting and they actually do get some absorption. Next slide, please. So back to patient S, again, 35-year-old episodic migraine, getting some relief, but maybe under treating her headaches. Again, I would consider a rotation of triptans and NSAIDs, so she gets a highly effective dose and a dose that just gets rid of the headache. I would start a GPANT as an option, reiterating non-use of the medication in pregnancy. I would treat and reiterate doing so early and aggressively, and just keep considering the mechanisms of action and try to rotate so you're not using the same mechanism of action every time. I would discuss medication overuse headache and warn her about it so she knows if she's starting to get 4, 5, 6 headaches a month. I want to know about that and give her a headache diary to assess the need for prevention. Next slide, please. Okay, so let's go to the second patient and we'll talk about prevention. So to treat or not to treat, patient B is a 62-year-old male with controlled hypertension whose migraines have been more frequent over the last year. He's getting 5 to 6 headaches a month that he treats ineffectively with over-the-counter medications. He's taking amlodipine. So for sure, the answer is yes to treat. This patient is using over-the-counter medications, which he's probably overusing at this point, and he has some comorbid medical conditions that we need to consider. Next slide, please. So again, what each side thinks, I want everyone to start thinking about that. So this patient says, I don't want to have to take any more medicine. I already take medicine for my blood pressure and everything else. And I will have to take medicines for a long time and I don't want to. So I'm always thinking that and saying to these patients, the headaches are going to be hard to control on just abortives alone, and medication overuse headache is probably happening here. So I have that discussion with them. I also always tell most all of my patients that forever is a long time, and I only try to keep people on prevention for a few months or a limited time to get things under control, to try to quiet down all the abnormal signaling and excitation that's happening in the brain. Next slide. So it's a very similar concept to abortive therapy. Migraines make migraines given the central feedback signaling problem. There's increased excitatory signaling in chronic migraine. With central sensitization, there's increased allodynia as well. The purpose and goal of preventative therapy is to make headaches less severe and less frequent. That should be the priority. And this is especially true in likely medication overuse headaches. Given the disability of and quality of migraines, even less frequent headaches should be considered for treatment. So I even start to consider prevention in patients that have 2 to 4 headaches a month, that they're out of work or they're vomiting and they can't function. So I want people to know that. Next slide, please. Okay, so back to patient B, 62, controlled hypertension on amlodipine, taking over the counters with 5 to 6 headaches a month. He adds that he has trouble sleeping. So he needs a preventative medicine. The considerations are age, comorbid conditions such as hypertension. And now I think about his sleep issues. So if we can find a medication that will kill 2 birds with 1 stone, we're going to try to do that. Next slide, please. Okay, so I'm going to go through all the, I'm going to go quickly through the preventative medications, and we'll get back to the patients. So beta blockers non-selectively antagonize beta 1 and beta 2 adrenergic receptors. The side effects include fatigue, decreased heart rate, impotence, and heart block. I do consider these patients for use that have elevated blood pressure, anxiety, and then I have to consider their age and sex as well. These are effective medications that can really help migraine. And the overall thought about how it works is sort of anti-excitation. Next slide, please. Similar story for the calcium channel blockers. They inhibit calcium ion influx into vascular smooth muscle and myocardium. Again, thought to be anti-excitatory on blood vessel channels. Tends not to lower the blood pressure and heart rate like the beta blockers. This is used off-label a lot for vestibular migraine. It seems to work very well. Side effects most commonly are constipation, and just consider other risk factors such as heart block and comorbid conditions. Next slide, please. So anticonvulsants consideration, this is not an exhaustive list, but includes topiramate, lamotrigine, zonisamide, gabapentin, carbamazepine, and valproic acid. Unclear mechanisms of action, but tend to be anti-excitatory as well. It works on sodium and calcium channels in the brain. Side effects that we worry about: metabolic acidosis, dizziness, fatigue, kidney stones, glycoma is on that list as well, which I didn't put on here, and often requires more monitoring than the other medications. Next slide, please. So just a few tidbits about these as well. Topiramate causes weight loss. Patients are always considering a side effect is weight loss or weight gain. Valproic acid can cause LFT elevations and strongly contraindicated in pregnancy. We don't tend to use that as much here anymore. I don't in my practice. Gabapentin can help with sleep, and lamotrigine is actually a good mood stabilizer. Next slide, please. Tricyclic antidepressant considerations: inhibit norepinephrine and serotonin reuptake. Side effects include fatigue and dry mouth and weight gain at higher doses. This medicine may help with sleep and anxiety, and you have to consider PR prolongation at higher doses. Next slide. The antidepressants, SSRIs and SNRIs, they selectively inhibit serotonin and norepinephrine reuptake. There's likely a more complex story in the mechanism of action in migraine. Actually, the SNRIs are indicated. The SSRIs are sort of second and third line therapy, but they do tend to work as well. This can help with comorbid anxiety and depression. Side effects, the common side effects are typically GI. This medicine usually needs to be tapered off, and there's side effects as patients come off, and some patients can have a paradoxical worsening of mood. Next slide, please. All right, so the new medicines, the CGRP antagonist, considerations and side effects. We have atogepant, imigepant, and the mAbs, including erinumab, eptinizumab, and furmananuzumab. So the mechanism of action, it inhibits the CGRP release in the CNS and trigeminal nerve ganglion. There are different formulations. The mAbs are injections. They're once a month. The pills are the Nurtec and the Qulipta. Again, availability is an issue for this around the world. Side effects include fatigue, somnolence, constipation, and local skin reaction. Atogepant has been shown to have statistically significant weight loss. And one of the positive things about this is that there's no real medical contraindications, which is very helpful. Next slide, please. Okay, so memantine considerations used kind of less often, but can be helpful. The mechanism of action is to block NMDA receptors. This is excitatory. There may be some glutamate contribution in this as well in the brain. It's anti-excitatory. Generally a very well-tolerated, and that should say tolerated, well-tolerated. And I often use this as a second line therapy and layering of medication when I use it. Side effects most commonly vivid dreams, and also needs to be tapered to discharge to DC. Next slide, please. So botulinum toxin consideration and side effects. The mechanism of action is complicated and not completely understood, but likely works in muscle relaxation, but also probably really works by blocking pain signaling centrally in the brain. So this medication requires injection by a qualified professional every 3 months. The side effects that are common are headache and actual potential for weakness. The availability is always an issue. It is expensive. Some of the other medications are expensive as well, but this it's a known availability issue. So there's also limited contraindications to other medical comorbidities, typically just myasthenia gravis, but generally very well tolerated, well studied in many patients, millions of patients. Okay, next slide. So let's get back to patient B again, 62-year-old male, hypertension, 5 to 6 headaches a month, likely medication overuse headache. The headaches, he also says, are increasingly causing disruption in his activities of daily living, and he has trouble staying asleep. So considerations, this patient definitely needs a medication for prevention. I like to reiterate that the medication will not be forever. And I also like to tell him, you know, if this is a medicine you're going to take every day, it will hopefully reduce the frequency and severity of the headaches. And he's already taking over-the-counter medications, which typically include NSAIDs, which can lead to peptic ulcer disease and are not great for someone with uncontrolled hypertension as well. I like to reiterate that it will help to reset some of the excitation in the brain, cool things off. He'll have less headaches. When he has to treat his existing headaches, it will be easier and less debilitating. It will be more effective, and they will not interfere with his life as much. Next slide. So again, discussing and reiterating that we need to do prevention. Forever's a long time. We can stop things at any time. I don't like these patients to believe that things are set in stone. I do like to discuss that trial and error is probably needed. A lot of times we have to start one thing and it doesn't work, and we have to stop it and try something else. Patients can get frustrated with that. Again, discuss the various options with him. So given his male sex and the side effects of impotence, I'm going to avoid beta blockers with him. He's already on blood pressure medicine, so I'm not going to particularly add another medicine. In contrast, there are some patients that have uncontrolled hypertension that I speak with their primary care or their cardiologist, and we decide to do a beta blocker or calcium channel blocker. So sleep is an issue for this patient. We landed on gabapentin after a discussion because gabapentin has a low side effect profile. It's good for migraine. We can use low dose and titrate up, and it will probably help him stay asleep. Another consideration would have been the tricyclic antidepressants, but there's no right answer here. So we try one thing and then go to the next. Next, we wanted to address the abortive use with this patient, reiterated getting off over the counters, and gave him a trial of Gepants, given that he has comorbid cardiovascular disease, and Gepants would be a good thing. One, because his body's not used to this mechanism of action. It will not cause medication overuse headache, and he's not a very good candidate for triptans. And even NSAIDs, if you're overusing NSAIDs, again, he can get peptic ulcer disease, worsening hypertension, and medication overuse headache. So the Gepants are a better choice for him and safe in his conditions. Next slide, please. So non-pharmacological strategies for migraine. Just want to do this very quickly because patients are always asking about this. They don't want to take medicine, even though we have all these treatments that are available, even after this talk about how it's necessary. There are other things we can do to help them. So just wanted to do some of the evidence-based supplements and some of the other things available. I tend to use magnesium glycinate or taurate. These were evidence-based and studied 400 milligrams a day. Mechanism of action, it likely helps to reduce excitation in the CNS. There was a theory that migraineurs had low levels of magnesium in the CNS. It's sort of been debunked, that theory, and hard to sort of measure, but it may help to reduce cortical spreading depression, and we think that's how it sometimes helps with migraine. The glycinate and taurate formulations tend to be easier on the stomach in general. A lot of the ones that are available, the oxides and the sulfates, either cause constipation or diarrhea. So I like to get them these other formulations that are easier. This supplement is safe in pregnancy. It's widely available and it's relatively inexpensive. Side effects are constipation or diarrhea, depending on the formulation. Next slide, please. So vitamin B2 is another one. It's also at 400 milligrams a day. It's overall well tolerated. Mechanism of action not so well understood. Sometimes it can cause flushing, and it is evidence-based that there is evidence to support this for migraine in particular. Next slide. Butterbur, also evidence-based for prevention. It inhibits L-type voltage-gated calcium channels, 50 to 150 milligrams a day. This tends to be more expensive, and important to tell patients to buy brands free of alkaloids and other plant carcinogens that actually have been shown to lead to hepatotoxicity. The alkaloids are the problem there. Contraindicated in patients using anticholinergic medicines and not approved for use in pregnancy. So a few limitations with this one as well. Next slide, please. So I get patients often asking me about neuromodulation devices. These are not, it's not an exhaustive list, but probably the most common questions that I get or that I use in my practice. We have remote electrical neuromodulation, the Rivio, non-invasive vagus nerve stimulation, gamma-core, the external trigeminal nerve stimulator, Cephaly, and the transcranial magnetic stimulation, the Savi Dual. There's another one, combined occipital and trigeminal nerve stimulation, Relivion. So the mechanism of action for each of these is neuromodulation via electrical impulses set to alter the pain processing in different nerve structures, including the vagus nerve, the sphenopalatine ganglion, and the trigeminal nerve. There is evidence in pain management for this, and also evidence now in migraine. It's well tolerated and safe. The cost and availability is variable, and in the States, you actually need to have a prescription to get this medication. They have preventative and episodic indications, safe and well tolerated. Again, I sort of tell patients that they can try this if they like to. Some people have good results from this. Some people, it feels like it's kicking the can down the road, and but they still like to use it. Next slide, please. So lifestyle changes, I think this is one of the last slides, but I always like to go over this with my patients. It's important. And these are the evidence, some of the evidence-based lifestyle changes that can help with patients. So I always tell patients to have regular sleep, same time to bed every night, same time up every morning. It doesn't have to be exact, but as much as possible. I have patients that get migraines on the weekends because they sleep late. That's the problem. Sleep is a big migraine trigger. Water doesn't have to be super crazy, but 50 to 60 ounces a day. Meals, tell patients to have regular meals without fasting. That's a big reason to have headache, and in a migraine patient, it can often trigger a migraine. Caffeine, for my migraine patients, I usually tell patients 1 cup to less than 1 a day. More than that, you can start to get withdrawal from caffeine. And just like a migraine overuse headache, you can actually get headaches from caffeine. Withdrawal, and then you get bad migraines. As far as food, everyone is always asking about food. In the evidence, MSG, tannins, and sulfates were the biggest sort of problematic chemicals for migraine. I encourage all my patients to do a moderate cardio 3 to 4 times a week. Biofeedback has been shown to help. And then, I do encourage meditation, acupuncture, but there's less evidence for those. Next slide, please. So again, just to summarize, overall, listen to patients and try to be heard as well. This is a communication, and we are providing education to these patients, which we have to always remember. Patients don't necessarily just want to be thrown medicine. They want to understand what's going on. And once they do understand these concepts, they are more willing to take medicine, which is better for their overall health. Again, education. They don't understand the need to treat. They don't understand or have expectation about the trial and error of medication use, and they forget what it feels like to be normal. I can't tell you how many of my patients have just been living with migraines for a long time, and then we start to get them under control, and they're like, oh my gosh, I I feel better. I feel normal, and I haven't felt like this in a long time. So just have your radars out about that. So there's a lot more treatment options now for migraine. It's a very highly recognized disease now, and the burden in the world is very high. Always consider comorbidities and try to take care of multiple problems with one medication. Next slide. So I think that's it. Thank you guys very much. This is my website. We see patients worldwide. I've been seeing patients worldwide, which is always interesting and fun to see what's available, and also to get help to patients that need it, because there's not so many headache specialists. These are my sources, and let me look in the chat and see if we can answer some questions.
Thank you, Dr. Riza, for this excellent presentation. It was a review for all the medication that we are using in our clinical practice. I'm going to ask you 2 to 3 questions that the audience asked us. One of them is interesting. Any role of steroids in acute migraine? Do you use steroids for migraine?
Absolutely. So I didn't have so much time to prepare every scenario, but there's so many scenarios. I use steroids a lot, not a lot, but I do use it as something to break the headache. So oftentimes we'll get a patient that has episodic migraine that lasted for a week or 2 or 3 weeks and it won't go away. I'll often go to a steroid taper for that. It's better and more effective and stronger than the anti-inflammatories, and I do use it. I use it a lot.
And
in that specific scenario.
Another question about hypertensive patients complaining of migraine. Do you use NSAID? Is it safe to use NSAID for hypertensive migraine patients?
So if you look at the data, it's not as safe. And actually I have had patients that have been using it on their own at home and had to go to the ER with blood pressures that kind of spiked into the 180s, 170s, 180s. And it tends to be a slower kind of raising the blood pressure in my experience for the patients, but I do not like using NSAIDs in patients like the one I presented at all. I really don't. And I do see that their blood pressure goes up. It's just that it's readily available to them. It's over the counter. And it's used for a lot of different pain syndromes, but it's typically used for ones that for a very short course. So, but I do see that, and I don't like to use it.
And my last question for you from the audience, do you have any indication of coenzyme Q10 in migraine?
So people always ask me about that. There is not as good of evidence as the other vitamins that I recommended. However, there are many people that take it, and there are many doctors in the US here that use that as another supplement. Also safe and well studied, so I think it's reasonable to use, also expensive. But I don't tend to use it as much for migraine particularly.
Thank you so much, Dr. Riza, for this excellent presentation.
You're welcome. Thanks, everyone.
And we're going to move for our second speaker, who is Professor Masoud Ashina. It's my pleasure to introduce Professor Masoud Ashina tonight. Professor Masoud is a chief neurologist and consultant. He's member of several professional societies. He's president of the International Headache Society. He's fellow of the European Academy of Neurology. Professor Ashina is a principal investigator of 4 ongoing phase 3 trials and 2 ongoing phase 4 trials. He's author of more than 600 papers, abstracts, and book chapters, more than 344 registered publications in PubMed. He had several awards and honors. Professor Ashina is actively involved in headache research since 1995. Professor Ashina, the floor is yours, and thank you for presenting for us our next topic.
Thank you, Dr. Rodi, for your kind introduction. Can you hear me?
Yes.
Yes. Who is going to show the slides?
Dr. Hussam?
Professor Ashina,
can you share the slides?
You can share your slides.
I can share my slides. All right. Yeah. Okay, let me do it. Just a second. Can you see my slide?
Yes.
Yes, perfect.
You can see my slide. Okay. Thank you very much for your kind introduction and for invitation to talk about very interesting topic. One simple solution for many migraines, role of rimegepant. So let me start with some of the disclosures. And then to move to the background of my presentation. Let me start with the anatomy and physiology of migraine. So anatomical and physiological substrate of migraine is the trigeminal vascular system, which you see on the left. Trigeminal vascular system consists of the cerebral vessels. They could be extracerebral, intracerebral, perivascular nerve fibers with the cell bodies in trigeminal ganglion, and then trigeminal spinal complex, and also brain. What the current hypothesis about migraine is that we have an activation of trigeminal vascular system, leading of the transmission of nociceptive impulses via the trigeminal nerve to the nucleus caudalis, the spinal nucleus, from there to the thalamus, or from the thalamus to the subcortical and cortical structures, eventually leading to the human experience of migraine headache with all associated symptoms. On the right, you see a very complex innervation of the vasculature. You see the different nerve fibers. I would divide them into two main efferent and afferent nerve fibers, releasing the different chemicals, including one important chemical that I'm going to talk about today, about CGRP, calcitonin gene-related peptide. So it's very important vasodilator involved in the regulation of the vascular tone. What we know that the CGRP is a therapeutic target for the treatment of migraine, and we also know that the CGRP receptor can be blocked either by the monoclonal antibody against the receptor or by the gepants, the small molecules antagonizing this receptor, but it can be also blocked by indirectly by blocking the ligand, the free circulating the CGRP, so preventing the binding of CGRP on the receptor. So we know that we have two classes of medications, monoclonal antibodies against CGRP or its receptor, or the gepants, the antagonist for against this receptor, CGRP receptor. Let me start with the acute treatment. What are the goals of acute migraine treatment? Well, according to the International Headache Society's guidelines for the clinical trials, the standard endpoint to evaluate the acute treatment is 2 hours pain freedom. So the complete relief of pain optimally in 2 hours or less considered to be a success, a goal for acute treatment. The second one is a relief of vomiting and associated symptoms. Sometimes we call them the most bothersome symptoms associated with migraine attacks. For the patient, what is important is the restoration of normal functioning, minimization of disability, and also prevention of headache recurrence, because most of the patients report the migraine attacks coming back the same evening or the same day or the day after. Then avoidance of the adverse drug events, and also we have to also think about the treatment of comorbid conditions. So as a general principle, the medications that are used in the clinical practice, they are to alleviate or remove the pain in migraine, and they should be administered at the pretty early phase, when the attacks, the headache is still mild. Here's a proposed algorithm that I published 3 years ago. And in this paper, I showed that the first line treatment, and then when the simple analgesics or NSAIDs fail, we can go to the triptans, and sometimes we can combine the triptans with the NSAIDs, particularly naproxen. Study showed that the combination with the sumatriptan and naproxen could be efficacious. But if all these let's say treatments are failed, we can go further and start treating patients either with the gepants or DTANs. And DTANs, we only have the one. On the right, you see the preventive treatment. Usually, we advise for the patients with at least 2 migraine days per month and adverse events despite therapy for migraine. We're talking about acute therapy. So there are some different unmet needs associated with the traditional acute treatments. So some of them are presented here. Well, the first one, tolerability issues. We know that up to the 43% of the patients, they experience adverse events within the 24 hours after intake of the acute medication. The second one is recurrence. We see that between something like a 60–80% of the patients, they experience return of pain within the 24 hours. Then there is an issue with the medication overuse. So overuse of many traditional medications, they can cause medication overuse headache. And the last one, for some of patients with the cardiovascular risk factors or the cardiovascular disease, there are some contraindications. And we're talking about approximately 2.6 million people in US. Now, this is a study that I'd like to present you with the Rimegepant, the Nurtec, orally dispensable tablets. And what you see here is superiority over the placebo after 2 hours post-dose for the acute treatment of migraine. So this is acute treatment of migraine. And the first diagram, the first here, you see it is the pain freedom at 2 hours. The 25% compared to the 11 after placebo, significant difference. And then freedom for the most bothersome symptom. Again, the significant difference between the Rimegepant and placebo. And the secondary endpoint was the pain relief at 2 hours. Here also you see the significant difference. The proportion of the patients of almost 60% compared to the 43% after the placebo, showing that the Rimegepant is superior. And what is important that 86% of the patients did not take a rescue medication within the 24 hours post-dose. So I'd like also to follow with the case, with the typical case that we have here is that we have a female patient, 36 years old, coming to the office with a long history of migraine, many years. And what she reports that a migraine twice a week and attacks can come anytime. Our patient tried different preventive medications, including topiramate and amitriptyline, which caused a significant side effects. Surprised? No. For her headaches in these patients, we have that the patient used acute treatment alternating paracetamol and ibuprofen. They could work sometimes, but for the severe headaches, the patient reported elytriptan, 40 milligram, the triptan. So according to the patient, it works, but she's done, with this same day because of the side effect. And we know this scenario. So she tried sumatriptan and she tried rizatriptan, but she didn't want to take them ever again, because again, it's all about the side effect. So she tried also to avoid treating the headaches and hoping that it will pass on their own. And most importantly, try to avoid the treating because of the side effects. So, and when she gives up, she takes the medication, and quite often she experiences that medication doesn't work. So this condition affects patient's life, work. She cannot plan anything, and the migraine can come anytime and ruin all her plans. So she's sick of having all this migraine dictating her life, and she doesn't want to take another, oral medication because of the side effects that she experienced before, including, the weight gain, experienced the brain fog after the medication. And she tried of deciding whether to take the treatment that may not work, but it will certainly cause side effects that will ruin her, day. This is, again, the typical scenario of the patients we see in clinical practice. So what can we offer her? Another triptan she hasn't tried, or maybe Nurtec, the 75 milligram Rimegepant, oral disintegrating tablet at the onset of her migraine. And we can also explain that there is not much to do. In some countries, unfortunately, we don't have the possibility to prescribe the medication, the new medications. So let's have a look at this data, which is very important data. And this data is a pooled analysis. And here you see that the efficacy of the Rimegepant in the different population. And what we see here is the pain and most bothersome symptom freedom 2 hours after the dose by triptan status. Okay, so on the left, you see the triptan naive population. Here you see the current triptan use in the middle. You see the history of triptan failure, at least one triptan, and history of the treatment failure with at least 2 triptans, more than 2 triptans. And what you can see across all population, you see the efficacy of this medication in terms of the pain freedom and the most bothersome symptom. And this is a statistically different. The key message is here that even in the patients with a failure for triptans, we can see positive signals showing that the drug, here in this case, rimegepant, is working. If we take the follow-up 6 weeks later, that our patients is back and reporting that the rimegepant is effective and stops her migraine without any side effects, and she takes right at the onset of her migraine, and she has no longer this fear, of the side effects. So, but she wants, to completely eliminate her migraine, and she gets at least, 1 to 2 headaches weekly. And now she also ready to try a preventive medication. And what will be the next step for our patient? Well, we can tell the patients that this drug, rimegepant or Nurtec, works also for prevention. She can take rimegepant 75 milligram every other day. And when she has a migraine, she can still use it as an effective acute therapy. So this is just to illustrate you that this drug provides you an all-in-one solution, acute and preventive treatment. So if we can conclude in terms of the acute treatment, we see that the significant proportion of patients receiving Nurtec, they were pain-free at 2 hours compared to placebo. And we also know that the Nurtec provided significantly better freedom of pain at 1.5 hours post-dose and significantly improved pain relief and ability to function 1 hour after the intake. And this is all compared to placebo. And then we have also the use of rescue medication within the 24 hours, the significant difference between Nurtec and placebo, and tolerability profiles was similar to placebo. And we also see that the most common adverse events on at least 1% of the patients were in both arms, and they included nausea, urinary tract infection, and dizziness. Importantly, no serious adverse events reported in the trials with acute treatment. Now, let's talk about the various factors that they may drive to the need for the preventive treatment. Well, attack frequency, it's very important because attacks that significantly interfere, with the patient's daily routines. Then the patient experiences so many attacks, per month, it can also lead to the significant burden. And we see the patients with a high degree of disability, including the different scales that we use. We also see the patients, they have a contraindication to acute treatment, okay, or acute treatment fails. This is also important. And very important point that the patients, we know that they may overuse acute treatments causing the medication overuse, headache, and there are some patients also experiencing tolerability problem. And overall, the goal of the preventive treatment is not to cure migraine, it is to reduce frequency, overall impact associated with migraine attacks, and reduce the overuse of acute medications, which may lead to the medication overuse headache. Now, what about the challenges? The challenges with the traditional medications is the late efficacy. It can take up to at least 2 months, up to 6 months, before we can tell our patients whether it is efficacious or not. So this titration period is important. And poor tolerability, which can lead also to the weight gain, fatigue, cognitive issue, depression, and all these are associated with the poor adherence and persistence with all these old medications. And this lead also to the high discontinuation rate. And this is what we see with with the preventive medications that we, until recently, we used, not specific for migraine. So here is a long-term safety study with rimegepant for the acute therapy. So pay attention, for the acute therapy. What we see here, what the patients start taking for the acute therapy, they also experience reduction in monthly migraine days. So in this open label, hypothesis generating, let's say, observation, we see that the patients taking rimegepant as needed experienced a decrease in monthly migraine days. So preventive effect. And what we see here that in this study, focusing on the prevention with a Nurtec rimegepant, we see a significant 4.3 day reduction, from baseline in monthly migraine days. And this is what you see compared to placebo, what was a significant. So this study met the primary endpoint. So in this case, 75 milligram during the 12 weeks trial, every other day exerted preventive effect in migraine. Here you see also the percent reduction of migraine days per week. And as early as week 1, you see significant difference compared to placebo. So rimegepant provided 30% reduction in weekly migraine days in the first week of treatment. And here again, a relevant case when we talk about the preventive medication. Here we have a patient suffered with an episodic migraine for many years, failed with the different medications, including topiramate, propranolol, all of them causing side effects. And she also takes acute therapy daily and multiple times a day. Okay. And for social history, we see that she got married half a year ago, and she had a nice honeymoon, but everything was, destroyed. She was supposed to have a honeymoon, and everything was destroyed because of a migraine. She wanted to try different preventive medications, and somebody told her, but, there is also some new medications, the biological therapies, that therapies can also change, her life. So she wanted to get her headache or migraines under the control. Here the diagnosis: episodic migraine without aura and medication overuse headache. What can we recommend to our patient? Another oral preventive, valproic acid? No way. It is, I would say, a dirty drug. We usually don't use that with women that they have the risk, you can call it, to get pregnant. So it's a teratogenic drug, so we don't use that. Consider monoclonal antibodies. The problem is with the monoclonal antibodies also that if she's planning a pregnancy, it can take a lot of time before she starts planning the pregnancy because of the long half-life. Increase the dose of her propranolol. This is also the possibility. Or the start Nurtec, 75 milligram every other day for the preventive treatment of episodic migraine. This is another option. So what we know here is the pivotal phase 3 trial in the patients treated with rimegepant for migraine prevention. And those patients experienced significantly greater reduction in mean monthly migraine days compared to placebo. So here you see that the baseline mean was 10.3 in the rimegepant treated patients and 9.9 in placebo treated patients. Similar. The patient treated with rimegepant 75 milligram every other day, they reported a 4.3 day reduction from baseline in mean monthly migraine days. So that was significantly different. And another important point here is that the change in mean number of monthly migraine days during the 16 months treatment periods, which also included double blind and open label period. This tells us about how sustainable this effect is. And what we see here, there was a 6.2 day mean reduction from baseline in the number of monthly migraine days averaged over the 16 months treatment period. Let's see about the follow-up. What is important is to explain for the patient that these new medications are not magic. We cannot cure the migraine. Lifestyle challenges that we also heard from the previous presentation, still very important. What expect the significant improvements, but only small minority, can go down to zero, okay? And sometimes they don't work. It's important to tell the patient. So it's important to acknowledge that so we don't have a false expectations. So what we can conclude here from this study I showed you on the migraine prevention, that the Rimegepant was significantly different from placebo on the primary endpoint of change on mean monthly migraine days during the 9 to 12 weeks relatively to initial 4 weeks of the baseline period. What we also see that Rimegepant showed the benefit on the proportion of participants who experienced at least 50% reduction in mean number of moderate to severe migraine days. So it meaning also working on intensity. And a great reduction in migraine frequency was seen in Rimegepant group compared to placebo through the 3 months, the whole period. And what is important when we talk about the prevention, no expected or serious safety issues, unexpected serious safety issues during this study, and tolerability was similar to that of placebo. So just, the key point here that the people with migraine, they do not want to take multiple medications. And what we have unique about this new class of medication is that the patient preference should be considered when we decide the treatment plan. And here we can provide them with the one solution, with acute and preventive treatment, and we can control the situation. So until recently, no medication been previously approved for both acute and preventive treatment with migraine. Okay, so triptans never been approved for migraine prevention, only for the acute treatment. And here we have a very unusual and unique situation. So this is some important safety information. So it's all on drug label. I need to show you that. And also adverse reactions, drug interactions, and use in a specific population, including the pregnant and breastfeeding. So we don't know at present whether it can harm an unborn baby or if it passes into the breast milk. So it's very important. So, and we have to avoid, the patients with hepatic impairment. Some abbreviated prescribing information here. And thank you for your attention.
Thank you, Professor Ashina, for this very informative presentation. I'm gonna ask you a few questions from the audience. One of our audience asked about any indication of Gepants or Rimegepants for pediatric patients. Is it safe to prescribe it or still contraindicated?
You cannot say it's contraindicated because it's not studied yet. I mean, but I'm sure that there will be trials, if not any trials already ongoing. Right now, we cannot prescribe that because we don't have any evidence for that. So when evidence is there, we can prescribe also in this population.
Another question, is it safe to combine Gepants with other monoclonal antibodies, anti-CGRP monoclonal antibodies?
Yeah, as an acute treatment, I cannot see any problem, when you use it on and off. But if you start using as a prevention, then it becomes complicated. Then you have a double prevention without any evidence for that. So I wouldn't do that.
And one of our audience is asking any evidence about migraine surgery. Maybe he means by surgical treatment for migraine.
No evidence, and we don't use it.
Okay, and maybe one of our questions about pregnant women that you answered us by one of the slides. I'm going to ask you a question, Professor Ashina. Is there any biomarkers for migraine? Because some of our patients in our clinic, they asking us like anything that can confirm us that we have migraine. What do you think about that?
Currently, we don't have any biomarkers. You cannot take a blood test or you do the imaging to diagnose migraine. Migraine is a diagnosis purely based on the clinical features and the international classification. There is a very simple way to study migraine. And what I can do is that I can put on the chat, a very good article, which is free online. It is a migraine, 10 steps. And this article, it's a very easy, in terms of the information that you get in this paper, it's sufficient for any physician to diagnose migraine. So you don't need any blood test if you just follow these 10 steps that I'm gonna now put that in the chat. And you can also share it with all your colleagues that asking this question. Let me put it in the chat. So you should have it now. So
yes, it appeared. Okay.
Yeah. So I suggest that you share with everyone this chat. This link, and everybody can see this paper. No, we don't have biomarkers, the migraine diagnosis, how to diagnose. It's all written in this paper.
Thank you again, Professor Ashina, for this amazing presentation. Thank you,
Dr. Rodi, just allow me, I have a question for Professor Ashina. I want to take advantage that he is with us tonight. So Professor Ashina, what about botulinum toxin for the treatment of migraine when it is indicated in this therapeutic area?
Yeah, oral botulinum toxin A, it's a registered and licensed for chronic migraine. Okay, so a chronic migraine is that when your patient has at least 15 days headache days per month, at least, and 8 out of these 15 days fulfill the criteria of migraine, then you have a diagnosis chronic migraine. So one example could be 8 days with migraine and 22 days with a tension type headache. Migraine will overrule that and you will call it chronic migraine. So in these cases that we have at least 15 days or more headache days and migraine at least 8 days, the oral botulinum toxin A is indicated. So in this group of patients, you may try. Usually we try 2 cycles, one, and then in 3 months, another one, and the patients come back in 6 months. If they're happy, if you have a reduction in migraine days or reduction of headache days with a moderate and severe in intensity, at least 30%, I would say, then you can continue that. But if you don't have any effect, then you can stop and give, let's say, monoclonal antibodies or the GPANs. It all depends, on the patient's preferences and let's say your own style, how you approach the patient.
And Professor, Dr. Rodi just asked you about the indication of Rimegepant in pediatric population. So as you mentioned, we don't have currently any data or recommendation to use it in this population. What are other alternative options that we can use for the treatment of pediatric migraine patient? And we heard a lot about the off-label use of candesartan for this population. Can you comment or elaborate on this, please?
Yeah, I mean, first of all, fortunately, in children, migraine is quite often has an episodic character. So it's a very episodic and can be controlled in most of the cases by acute medication. Okay, and we can use sumatriptan nasal spray, 10 milligram in this population, and some people also use off-label small, let's say, half doses of the triptans. Let's say half dose of the sumatriptan, let's say 25 milligrams or 5 milligram rizatriptan or something else. They use that off-label, the colleagues. But after the age of 12 years old, the 10 milligram was started nasal spray sumatriptan. In terms of the prevention, you can use beta blockers, you can use also candesartan off label. But what is interesting is, Dr. Maya, is that in Denmark, traditionally, the many, my elderly colleagues, they use pizoxifen, which is a 5-HT antagonist, the old drug for prevention in children, and also flunarizine, Sibelium in children population. Yeah. But I don't like these drugs personally. So if I have children to treat, it's not so often I get children in my clinic. I would personally use off-label, the small dose of beta blocker and all candesartan. You can use that. But I'm waiting now for the status with monoclonal antibodies. I know that the studies are ongoing in this population. And maybe also with the GPANs, we will also hear that. So hopefully we can use them in the future.
And the final question from my side. So if a patient is failing one of these anti-CGRP therapy, do you recommend to shift to another anti-CGRP? And do we have evidence currently or any recommendation about combining anti-CGRPs? So given a patient, for example, I have seen in the UAE some neurologists in their practice who prescribe like IV anti-CGRP or who combine IV anti-CGRP with the subcutaneous one. What do you think about this practice?
First of all, no evidence for combining. Secondly, it's a really, let's say, cowboy style of doing this, double dual therapy. It's quite brave from their side. I wouldn't risk doing that because I don't know anything what's going to be if you block so much, let's say, the CGRP, which is a very important molecule for human body. So I wouldn't do that. First of all, no evidence, and then I would also be concerned about the possible, side effects of that. Regarding that, if you have one drug fail, whether there is a rationale to choose another one. Well, in different countries, we have different regulations. In Denmark, we are not allowed to switch due to lack of efficacy. We can switch due to side effect tolerability issues. Okay, but my personal opinion is that we should be able to switch to another because we cannot exclude the different profiles of patients like we see with the triptans. That when we treat with a sumatriptan, doesn't work, we take a rizatriptan, it works perfectly well, or vice versa, right? So I think that this option should be there, and we should be able, to prescribe this different medication. To do clinical trials in this field, it would be impossible. You cannot convince any company to do this kind of studies. So that will be based on our experience.
Thank you so much, Professor Ashina. Thank you also for Dr. Riza Ravitz for the first talk. I would like also to thank IVPN NeuroPsychiatry, Association of Migraine Disorder, and Pfizer for this migraine masterclass for tonight. I'm gonna leave the mic to Dr. Maya to keep us updated for the next events. Thank you so much.
Thank you.
Thank you, everybody. And let me thank Dr. Rodi Nawar for moderating this session perfectly. So thank you, Dr. Rodi, for being with us tonight and staying with us until the end. You are always the most welcome, and you will be our speaker for our next webinar, also discussing migraine therapy. So we'll be seeing you like in 2 weeks period. And also let me thank Dr. Riza and Professor Ashina for accepting our invitation and for their excellent presentation. Also, thank you for Pfizer for sponsoring this educational activity, and for the Association of Migraine Disorder for this collaboration. At the end, I would like to thank our attendees for staying with us and until the end of this webinar. And I would like to remind them that they will receive their certificate of attendance within 1 week from today by email. And also, if they missed any part of this lecture, or if anyone would like to revisit the lecture, they can visit our IVPN library, where all the recording of this session will be posted also within 1 week from today. Also, follow us on LinkedIn by joining our IVPN NeuroPsychiatry page to stay updated on all our upcoming educational activity. And our next activity is scheduled on May 4. It's our second Neurostat series, and Dr. Rodi will be our speaker during this session. Then we'll be having on May 18 another educational activity about update in psychiatric diseases, mainly schizophrenia, treatment-resistant depression, and multiple sclerosis. And on May 25, we'll be having our 5th migraine master class. So follow us on our social media platform. Always stay tuned for innovative educational activity. And until I meet you again, stay safe and have a good night, everybody.